Hi, good afternoon, good morning, everybody. Welcome to this session. So we will wait 30 seconds and then we will start. Today we welcome Dr. Ganassia, who is working in SET and also in the American Hospital of Paris. And so welcome, Dr. Ganassia. And today, if I'm not wrong, you are going to talk about the main lesion of thyroid in ultrasound. And also, you will explain a few things about the therapy, right?
Right. Hello,
okay,
Florence.
Perfect. Hello. Thank you for being with us, and I leave you the floor.
Okay, so good afternoon, everyone. Thank you for being here for this webinar I called Thyroid Ultrasound Examination from Lesions to Therapy, a double meaning dream. Why a double meaning dream? Because first thing, I think that we all know that now for diagnosis, ultrasound is a state-of-the-art exam, but also for therapy, to prepare for therapy, but also to manage now ultrasound-guided therapies like thermal ablation. And that's double meaning dream because for myself, I dreamed when I learned ultrasound to be able to diagnose, but also to treat one day. And the day has come, and I'm very happy to share my experience with you. These are my conflict of interest. Most important of all, I have a passion for ultrasound. That's my main conflict of interest. So I'm part of the thyroidologist world. What is a thyroidologist? It's an endocrinologist mastering ultrasound and ultrasound guiding techniques, but of course integrated in a universe of other specialists around the patient. So what is the core of thyroid ultrasound as thyroid disease is thyroid cancer. And 5 years ago now, we had this article from New England Journal of Medicine called Worldwide Thyroid Cancer Epidemic, the Increasing Impact of Overdiagnosis. And a French surgeon called Jean-Louis Pex wrote in the Annal of Surgery, French Annal of Surgery, one can wonder why we are referred so many patients for thyroidectomy. Why would these unlucky thyroids join uterus in the community of endangered species? The man said it all. So it was a shock for us because we all wondered, thyroid endocrinology, thyroid imaging practitioner, what to do, what not to do. And here is the example of ultrasound wasted. In Korea, general practitioner GPs were given ultrasound to for breast cancer, okay, to check for breast cancer, and they went to the thyroid and found a lot of nodules, a lot of thyroid cancer, and look at the incidence of thyroid cancer. And one day they said, "Oh, whoa, whoa, whoa! Stop! You are going to kill more people with the treatment than with the disease." And you see that the thyroid cancer incidence increased, but the mortality did not decrease. So they say, stop the madness. And then physician call to stop screening led to a decrease in thyroid cancer, micro cancer incidence. So the core of our reflection for thyroid lesions is the acceptable risk of benign, because diagnostic strategies are not 100% accurate. You can't achieve zero risk. So what's the acceptable risk to miss a cancer, and what is the consequence of missing, of voluntarily missing this cancer? It's a question you have to ask to yourself, to your patients, and to the country you live in, to the society. So it's not, of course, the core of our debate today, but you have to tell yourself that when you check for a lesion, what is your location in the diagnosis. So this is the essence of thyroidology. The essence is conservative strategy on principle, but cautious. It's not a war against surgery. We always check on the patient's choice. And to manage this, it means that thyroidologic diagnosis must be rehabilitated. Too many times we say, oh, you have thyroid lesions. Okay, go to the surgeon. He will take your thyroid away and we will see what it was. No. Nowadays, we cannot accept this strategy. So the thyroidologic diagnosis checks, of course, for clinical examination, blood tests, imaging techniques, but for goiters and nodules, for hyperthyroidism or for hypothyroidism, thyroid ultrasound is the state of the art exam. Let's have a look at these different thyroid pathologies and now thyroid nodules, diagnosis and follow-up. Ultrasound makes the diagnosis of nodule. What's a nodule? It's a small rounded lump of tumor-like tissue you must see in two orthogonal planes, distinct from the surrounding by its borders, its contrast, its mass effect. And this excludes pseudonodules generated by a vessel, a septum, or a thyroiditis. And it's an essential prerequisite to avoid an unnecessary process. Okay, you will check all the blood tests, etc., for something which is not a nodule. What a waste of time, what a bad diagnosis step. But the main interest of ultrasound is the stratification of malignancy risk, thanks to the thyroids. And it helps, thyroids help for the FNAB indication, and also, more recently, for active surveillance criteria. What is the main question when you have a nodule? Treatment or follow-up? What are the indications? First, unacceptable probability of malignancy. That's why I talked about acceptable risk. The patient's choice, aesthetic or functional, or I would say psychological discomfort, overt or subclinical hyperthyroidism, and main axis more than 3 or 4 centimeters. The aim of the process is to look for and often validate these indications with 3 exams and 3 steps. First step, TSH, calcitonin, so blood test, and ultrasound. You put them on your desk and then you start thinking. Thinking about what? About the 2 other exams. Should we perform a scintigraphy? Should we perform an FNAB? And then, should we treat and how to treat? Should we perform scintigraphy as a first step? Indication to perform a thyroid scan relies on TSH, but sometimes, and we will see this, on expert ultrasound. Why do we perform scintigraphy as a first step before FNAB? Because autonomous nodules are always benign. FNAB is futile. And autonomous nodules, given indeterminate cytology, quite often FNAB is worrisome. Indeterminate cytology preclude conservative techniques. FNAB would be counterproductive. So look at this. Imaging techniques can lower the risk of malignancy from 7 to 15% to 0 and avoid FNAB. Controversies exist because there is always someone to say, oh, but I had an autonomous nodule that was cancer. Problem is that these studies, they have flaws, but I don't have the time today. We can discuss it later. But controversies of this paradigm lack strong arguments. An autonomous nodule is always benign, period. Autonomous nodules. Of course, everyone knows about toxic adenoma, plumber's adenoma, with low TSH, FT3 and FT4, totally extinctive on scintigraphy. And pre-toxic adenoma, with low TSH, but normal FT4 and FT3, partly extinctive on scintigraphy. These two have a low TSH, so they can be screened at the first step of the diagnosis. But before being so huge that they can cause a low TSH, they are smaller. The functional mass of cells is smaller, and it gives euthyroid autonomous nodule with normal TSH, not extinctive. And these ones are not referred as a first step with scintigraphy. 50% nodules associated with TSH between 0.5 and 1, so normal, are autonomous, and 20% with TSH from 1 to 2. But look at this aspect. This is a thyroid 4 nodule, hypoechoic, with some cyst inside and highly vascularized. TSH is 1.8. It's not a medullary carcinoma. And then, because it has these aspects, then we can ask for a first step scintigraphy and see that this is a euthyroid autonomous nodule. It is benign, no need for FNAB. But, okay, we consider it's not autonomous. Should we perform FNAB? According to the country, many criteria can be used, but always ultrasound. In France, for example, we combine clinical, biological, and ultrasound features. What are risk factors that indicate FNAB, except for thyroid 2 or tier 1 or 2 in the US system? You have them here. Some of them are more recent, like a family history of thyroid papillary or follicular cancer, okay, but they are quite classical. If you don't have these risk factors, you can have a clinically suspicious nodule. What is a clinically suspicious nodule? It's a hard, rapidly growing nodule at the middle of the lobe, quite tender. This is in favor of medullary carcinoma, compressive, or PET scan incidentaloma. Clinically suspicious nodules indicate FNAB, except for thyroid 2 or tier 1, 2. So this is the thyroids. The thyroids is a 3D imaging reporting system allowing the quantification of malignancy risk. Euthyroids 5 are high-risk nodules with 4 cardinal signs described by Mrs. Kim in South Korea 20 years ago. The taller than wide shape, you can see here. The irregular margins, lobulated or spiculated, the microcalcifications, and markedly hypoechoic. It is hypoechoic because it's less echoic than the thyroid, and markedly because it's less hypoechoic than the muscles. Wider than tall, so it's a reassuring sign. Okay, in France now we say disharmonious. It's the same shape as the lobe, whereas taller than wide, it's orthogonal to the lobe main axis, and it is suspicious because it vanquishes the gravity. Regular margins are reassuring, and you see, even with high resolution, that you have a wonderfully regular margin. Whereas when you have ill-defined margins, well, it's neither suspicious nor reassuring. It's not in the thyroid score. When you have speculations, at least 3, it's a sign of invasive cancer. It's an invasive nodule, so it has high probability, big cancer, and you see them here with these little spikes. And you have the equivalent that are the lobulations, more rounder, but you see here, you can count more than 3 of them. It's highly suspicious. Markedly hypoechoic, as I explained. And you must notice something, little trick, little hint, is that sometimes hypoechogenicity can be created by anterior structures like muscles. Okay, one cannot create an artifactual isoechogenicity. When you see in one of your pictures that it is isoechoic, then isoechoic it is, even if in another plane you have an hypoechoic or the impression of hypoechogenicity. No, one cannot create an artifact to isoechogenicity. The less reproducible, are microcalcifications. If you want to be rigorous, you have to check for 5 criteria: hyperechoic foci, round, rarely linear, diameter under 1 millimeter, no shadow cone, and no comet tail artifact, just like here. And you must not be confused with colloid granulations, which are hyperechoic foci, possibly more than 1 millimeter, inside colloid, with comet tail artifact, and they can move. If the patient sits, then you see them move. You have something between both, microcystic cavities. These are hyperechoic foci in the depth of microcystic cavities. To see them clearly, you must deactivate the compound mode, and then you will see in this hypoechoic nodule totally anechoic little cavities with this hyperechoic foci. You see, it's constant. Here is another example that can be, microcalcifications, but when you zoom, you see that above each hyperechoic focus, you have this little anechoic zone. Euthyroids 4, intermediate risk, it's no cardinal sign, mildly hypoechoic, wider than tall, regular margins, even partly hypoechoic. If you have a two-faced nodule with an isoechoic part and a hypoechoic part, the hypoechoic part wins, okay? Euthyroid 3, you have low risk, isoechoic, wider than tall, regular margins, no cardinal sign, with isoechogenicity, it's a euthyroid 3. Isoechoic nodular cluster are considered euthyroid 3. I consider the larger nodule inside, more than 2 centimeters, okay? But sometimes I perform FNAB only in 4 centimeter isoechoic nodular cluster. Euthyroid 2 is benign, okay? You have 2 types of nodules, the purely cystic nodules and the spongiform nodules. Very typical, okay? These are always benign. Ultrasound predicts benignity, okay? It is always benign, no need for FNAB. So what are the expected results of the thyroids? It's a study by Tramaloni and Rus to expert ultrasound practitioners. And they concluded that in your results, you must have 5% thyroid 2, 5% thyroid 5, 2/3 of thyroid 3, and only 1/3 of thyroid 4. If you have more thyroid 5 nodules, then it's a matter of anxiety. After this, my first message is that thyroid score matters, okay? Thyroid score is the core of the process and leads to diagnose 96% of cancers. But you also have, accessory signs. So thyroid ultrasound of nodules is not only the thyroids and the cardinal signs. You have the peripheral incomplete macrocalcifications. When it's complete, it's reassuring. But when it's incomplete, like here, so it's a little increase of the risk of malignancy without changing the thyroid score. The round shape the oblique shape and the extrathyroidal extension slightly increase the risk of malignancy. Whereas accessory signs that decrease the risk of malignancy, some of them are very classical, like the halo, thin and complete halo, has always been known as a reassuring sign, the cystic component, the colloid granulations, and the flattened shape, length more than 2.5 width. Let's talk about vascularization, color Doppler, of a mid-end. It's controversial data, and it's not included in the thyroid score around the world. It does not provide any additional argument compared to the B mode. Okay, and I personally have many non-vascularized cancers and many very vascularized benign nodules. It can have a small interest in totally solid isoechoic nodules more than 2 centimeters, with a central vascularization associated with an increase in the risk of malignancy, and peripheral vascularization that lowers the risk of follicular carcinoma. But a little argument added when you are completely in an indeterminate cytology. Of course, if you accept the malignancy risk stratification, it can distinguish thick colloid and solid nodules. It can help to diagnose, as we saw, an autonomous nodule, and it has a role in US-guided techniques to avoid vessels. So here are some examples of the use of B mode. You see here, if you perform an FNAB, you are happy to know that you will avoid this zone. Same remark for thermal ablation. Elastography now. Vascularization of a mid-end, elastography of a mid-rise. There are controversial data, so it was not included in many thyroids. It has been included in the French thyroids by Gilles Russe, but removed from the European thyroids. Yet, isolated, it has the best sensitivity and specificity. But there are many limitations, okay, and a huge inter-operator variability. Also, it cannot be used for big nodules, for nodules close to trachea, if there is a big cystic component, if there are macrocalcifications, and there are many cutoffs. So it's not that elastography is not a good sign. It lacks of standardization. And I hope that in the years coming, many people will be interested to perform studies to standardize elastography and to use it to give it its right place. Okay, so you can use strain elastography, just like here, but it's semi-quantitative. Okay, you can compare this with the tissue at the same level. The best is to perform shear wave elastography, like here, that gives you in kilopascals the rigidity of the nodule, and that can help when you hesitate to perform an FNAB. Should we perform an FNAB? So now you have the answer thanks to your ultrasound. If you have risk factors and the nodule is more than 10 millimeters, you perform. No risk factors, okay, you will perform euthyroids 5 more than 10 millimeters. You add thyroids 4 at 5 millimeters, and you add thyroid 3 at 20 millimeters. Less than 10 millimeters only in an oncologic context, or euthyroids 5 growing close to capsule at the upper pole with a suspicion of multifocality or age under 40. You see how ultrasound will help you to answer this question. So you see that there is a flexibility because context and accessory signs help to modulate FNAB indication within each category. But still, do not worry. It's only an FNAB. So even if you limitate, okay, your indications of FNAB, but you hesitate, do not hesitate. It's not a big decision. Okay, if I have a doubt, now I will perform. And perhaps in 5 or 6 years, when I see that for this sign, all of my FNABs are benign, okay, I will calm myself. And perhaps for this patient, before I would have asked FNAB, not now. Of course, there must be a standardized report useful to the clinicians, useful to the other care providers, okay? And on this standardized report, you always must have a scheme, a drawing your nodules with the diameter of the volumes will help much more than 15 lines of text nobody ever reads, except lawyers. Another use of ultrasound, it's before a lobectomy, okay? Volume measurement helps to predict thyroid autarky. When you have a residual volume more than 5 to 6 milliliters, which is the lower rate of volume to talk of normal thyroid volume, under 6 milliliter, you said it's thyroid atrophy. Okay, so when it's more than 5 to 6 milliliters, that can predict self-sufficiency. So you see, it's very important to have a preoperative ultrasound to be able to talk with the patient. You can also predict or try to predict the future of the residual lobe. If there are nodules, if there is dystrophy, if there is thyroiditis, you can say to yourself and to your patient, perhaps we will not avoid levotiroxine treatment. So that allows clinicians and surgeons to discuss the probability of hypothyroidism after lobectomy and to choose with the patient between lobectomy and total thyroidectomy. Ultrasound matters. So if we conclude, nodules, ultrasound allows with scintigraphy the diagnosis of nodule versus pseudonodules, the diagnosis of autonomously functional nodules, the stratification of malignancy risk, the nodule diagram, and the prediction of autarky. Ultrasound matters. Let's talk now about thyroid cancers. It allows the diagnosis and the follow-up. The main role of ultrasound is, of course, follow-up after surgery. You have here the 2013 guidelines of European Thyroid Association, written by a group led by Laurence Lénart, and it shows that there is a recurrence in lymph nodes in 75% cases, in the thyroidectomy zone in 20%, and in the soft tissues in 5% cases. So you see that in all the exams needed for follow-up, neck ultrasound will be indicated in low-risk cancers only if you have an elevated thyroglobulin or an abnormal palpation, and will be systematic in high risk, in cancers with high risk of recurrence. In the thyroidectomy compartment, you can find remnants. Here you have a nice remnant, isoechoic. It has a wider natal shape, regular margins, and a poor vascularization. Here, vascularization can be useful, whereas you don't have any cardinal sign. Whereas a recurrence, you can use the cardinal signs of TIRADS. A recurrence in the compartment is hypoechoic, tall and wide, with irregular margins, microcalcifications, and vascularization. So you see the usual signs. You can find granulomas. Here, it's always non-vascularized and can be easily recognized. And sometimes you can find a parathyroid adenoma, more difficult to see because you don't have the contrast created by thyroid lobes. The lymph nodes. You must learn to distinguish between lymph nodes and adenopathies. A normal lymph node is like this. You see, it has a hilum, it has a long shape, okay? Vascularization is around the hilum, it's central vascularization, and there are no suspect signs, okay? It can be more rounded, but you see here, you always have the hilum vascularization. Whereas metastatic lymph nodes have 1, 2, 3, or 4 of these cardinal signs, but only one sign makes you consider this lymph node as metastatic or suspect for metastasis. Cystic cavities, you can find them also in tuberculosis, thyroid-like tissue, microcalcifications, and irregular capsular vascularization, but not with a hilum. So here's an example of a lymph node. You see here a cystic cavity, you see here thyroid-like tissue, you see here a microcalcification. So you must know these criteria that will indicate to perform FNAB with thyroglobulin dose in the washout liquid. You will report what you saw on your ultrasound exam on this diagram recommended in the 2013 guidelines of European Thyroid Association. You can be helped by other imaging techniques like iodine thyroid scan with iodine 131, okay, and also the PET scan to find if you have an elevated thyroglobulin, but you cannot see where is the spring of the thyroglobulin. You can help yourself with a simple diagnosis exam PET scan or iodine thyroid scan, which makes the diagnosis and the therapeutics. It helps also for the diagnosis of non-typical cancers, like diffuse sclerosing variant of papillary cancer, anaplastic cancer, and thyroid metastasis. Follicular and medullary cancers are diagnosed with the usual strategy with the thyroids, but less these ones. Diffuse sclerosing variant of papillary cancer. It's a young girl, generally, with TPOA antibodies poorly elevated and with a typical US feature, diffuse microcalcifications like a snowstorm. Cytology is often beta-1, non-significant. And why is so? Because you always go for the hypoechoic foci instead of going in the middle of microcalcifications. Always check the metastatic lymph node. It's constantly present. It's a lymphatic disease, so check for and perform FNAB for constantly present metastatic lymph nodes. Anaplastic cancer, older age, hard, rapidly enlarging and compressive mass, solid, hypoechoic, and poorly vascularized, with or without metastatic lymph nodes. I had a case like this. It looked like de Kervin thyroiditis because it had fever. It had an inflammation, but when I checked, it was not like de Kervin thyroiditis. It was like this. So I performed a microbiopsy, and unluckily, it was an anaplastic cancer mimicking thyroiditis, subacute thyroiditis. Thyroid metastases are less common, and I saw that many people, instead in cancer care centers, do not know about thyroid metastasis. It reveals cancer in 30 to 50% cases. The primary tumor will not be found in 20% cases, and it's an isolated metastasis in 30 to 50% cases. The most prevalent is a metastasis for kidney cancer, and after this, colorectal, breast, or lung cancer. Kidney is a polylobed, hypervascularized mass with always constant jugular vein thrombus. You see here that must you must say, oh, looks like a metastasis for kidney cancer. Okay, and you must warn your immunopathologist, okay, to tell him, I think it can be kidney cancer. Can you perform immunocytochemistry? Here are metastases of lung cancer, usually goiter with hypoechoic streaks without vascularization. It's very uncommon. So when you will see this, it's very typical. Here you have the example of a lung metastasis, and here of breast. You see, it looks like thyroid 5 nodule, okay, but if it is an oncologic context, you must warn the pathologist. And if there are curious cells, always think of thyroid metastasis of another cancer. So that was the larger part, hyperthyroidism. Now we will talk about ultrasound and hyperthyroidism, useful or pointless. There are a lot of etiologies of thyrotoxicosis, okay? And thyroid dysfunctions have a very rich description with clinical signs, biology signs, etc. But for a rational diagnosis process, okay, so that your treatment will be perfectly adequate, you must have all the elements, and ultrasound signs are part of the diagnosis process. Let's talk about this case. Bright eyes, 42-year-old man with thyrotoxicosis, eyelid retraction, no Graves' orbitopathy, no goiter, but it has biologic thyrotoxicosis. Of course, you can diagnose Graves' disease with clinical test or blood test, but in B mode, you will have a very typical aspect with an inconstant goiter, hypoechoic, homogeneous reticulated, with vessels enlargement, lumpy margins, and pulsating. Look at this video, and you see it's hypoechoic, it's a goiter, it's homogeneous, okay, and you see the lobulated margins. Here you see the isthmus with tracheal rings. And most important, in color Doppler, you will see what is called thyroide inferno. In Italian, thyroid inferno, thyroid's hell, okay? With this huge vascularization, you cannot see thyroid parenchyma, okay? But the quantification of this is ensured by pulsed Doppler with the measurement of velocities and of blood flows inside thyroid arteries. Okay, here you have an idea of the peak systolic velocities of a normal thyroid, of autoimmune thyroiditis, and of Graves' disease. The cutoff is not always so straight. There are a little, sometimes it can be the same values, but in 90% cases, you can use these values to have a good differential diagnosis. So here, with a simple ultrasound examination with Doppler, color Doppler, and pulse Doppler, Graves' disease is diagnosed because more than 1 meter per second is pathognomonic of Graves' disease. So here, no need for blood tests, no need for scintigraphy. Another use in the usual strategy, okay, 18 months anti-thyroid drugs regimen, and you can use TRAB as a prognosis factor for early relapse, but that's all. 18 months treatment, we stop and we see what's happening. We have risk factors for relapse, of course, but in all the studies, the best Yoden index, the best prognosis factor is the peak systolic velocity and arterial flow. So once again, ultrasound. Here's a study by Misako Ueda, but you have other by Erdogan in Turkey, showing that in the inferior thyroid artery with peak systolic velocity that you have the best Yoden index to predict early relapse. Let's have a look with this block and replace regimen, antithyroid drugs and levothyroxine. Look at these two women. Both are euthyroid. Both are TRAB negative. This one, 10 months of treatment. Look, no more vascularization and 90 centimeters per second. 8 more months of treatment? Why so? At the opposite, this woman, 24 months of treatment. But look, always a goiter, still hypoechoic, still very enlarged vessels, still 150 milliliters per minute. Okay, shall we stop treatment? She will relapse. So pulse Doppler can reflect autoimmune activity and keep the patient safe from a relapse and from an unwished way to radical treatment. We can individualize our treatment strategies thanks to ultrasound and Doppler. Julian Léger now treats children for 6 years. Okay, we have encouraging results at 10 years, and there are TRAB modulating drugs under development. With pulse Doppler, we can keep the treatment for years for some selected patients and not condemn them to radical treatment. I am fond of this one. Bender process. 37 years old women, clinical thyrotoxicosis and mild orbitopathy, moderate homogeneous goiter. Thyrotoxicosis, TRAB, hugely positive. She performed an 18 months of antithyroid drugs regimen, and then it was discontinued. Classical attitude. I did not see her again. But then 2 months later, intense relapse. This time, she's referred to my office. And then, I'm sorry, I performed ultrasound because she did not have any ultrasound. It's a classical attitude in France. On my ultrasound, I have the classical signs of Graves' disease, but something more. Nodular formation in the left lobe with ill-defined margins and intranodular peak systolic velocities close to 2 meters per second. Look at this. So, okay, that's Graves' disease. But here, there is a nodule with high peak systolic velocities. And what did I say? When you have low TSH and a nodule, scintigraphy. And on the thyroid scan, you see a diffusely increased captation, a focal increased fixation in the middle of the left lobe at the level of the nodule. Semiology mix Graves' disease, autonomously functioning nodule, and the main hypothesis is Marin-Lennard syndrome. So you see here, you have diffuse fixation, but here you see that it's not like in the left lobe. What is Marin-Lennard syndrome? It's the coexistence of Graves' disease and autonomously functioning nodule in the tail thyroid. I think it's more a coincidence. And there are pitfalls like focal Graves' disease that exists, multi-heteronodular toxic goiter with TRAB, and radioiodine-induced Graves' disease after the cure of Plummer's adenoma. Okay, but most important of all, why is this diagnosis relevant? Because medical treatment will never achieve remission because of the toxic adenoma. So 24 months ATD regimen, a loss of time, you can predict an effectiveness, iatrogenic, blood tests, cost for patient, and insurance, hours not working, etc. That's not a good medicine. And that made a welcome debate. The relevance in thyrotoxicosis of ultrasound and scintigraphy. At the European level, the ETA said, okay, ultrasound in the first step diagnosis process for thyrotoxicosis, but not in France. It's about 2 to 4% of Graves' disease. The first article was by Marin and Lennard in 1911, but it was included in ATA guidelines in 1969, and I recommend to read the SHARK study. There are 3 on PubMed, very elegant, very precise studies of quantified scintigraphy. More recent cohorts showed 4% prevalence. This patient made a curious choice. From her understanding of the diagnosis, she chose a lobectomy for toxic adenoma, so the left toxic adenoma, and she wanted to end the ATD regimen for the right lobe, and she said, I will have radioiodine if necessary, or surgery as a last chance. So she had lobectomy. 6 months then, she discontinued antithyroid drugs because of normal vascularization and normal arterial flow at ultrasound and pulse Doppler, and she now have euthyroidism without treatment for 10 years, thanks to ultrasound. So now, Iodine, 16 years old, ischemic heart disease, with the treatment of ischemic heart disease, weight loss, and she has thyrotoxicosis, no antibodies. It's amiodarone-induced hyperthyroidism. The main goal is to distinguish type 1 and type 2 because the treatments are different. Type 1, antithyroid drug and surgery. Type 2, corticosteroids and surgery. These people have chronic heart disease, so one can be doubtful of the usual attitude, sometimes described, of the benefit-risk ratio of combined ATD corticoids regimen with the side effects. Many studies tried to distinguish type 1 and type 2, and all these studies, all the guidelines have the same conclusion. In North America and Europe, color flow Doppler was the procedure of choice in both regions. Why is that so? Because in type 2, you have a diffuse hypoechogenicity, homogeneous, with vascular desert and normal peak systolic velocities. If this is, and that's the most frequent, then corticosteroids. If it's not, then type 1 and classical treatment. A star is born. She's called Kelly. She has, as you see, slight low TSH with normal FT3 and FT4, no antibodies, and she's pregnant. So thyroid scan cannot be used during pregnancy. What is the cause of her thyrotoxicosis? Let's have a look at ultrasound, normal ultrasound with slightly increased vascularization, with slightly increased velocities, okay? And she has transient gestational thyrotoxicosis. That can help to distinguish for Graves' disease or other cause. You can use propranolol, but with one ultrasound, you can be reassuring, and relieve a pregnant woman is not pointless. The star strikes back. Always Kelly, always thyrotoxicosis, but this time, nice try, but not pregnant. Okay? And she has this ultrasound, a small thyroid, no vascularization, no abnormalities. Okay? With this, velocities being normal, totally normal, you must think about recommending a test for thyroglobulin, and low, this is factitious thyrotoxicosis. Nice diagnosis, but good luck for treatment. Want to buy some juice? A bottle or tin? Okay, she's 39 with multiple sclerosis, ambulatory sector for methylprednisolone bolus. And she has blood test, and look, she has a low TSH with increased FT4 and FT3, positive for TRAP, and she's totally asymptomatic, peaceful, with a Zen attitude. Ultrasound is totally normal. So you will say, thyroglobulin, nice try. No, it's normal, it's at 38. So, wanna buy some juice? A bottle or a tin? Buy a tin. Oh, all right, buy a tin. Okay, biotin can create a totally artifactual biologic description of Graves' disease with low TSH, high FT4 and FT3, and high TRAB. So when you have thyrotoxicosis with normal ultrasound, think of factitious thyrotoxicosis, of toxic ovarian goiter, of transient gestational thyrotoxicosis, or biotin. We will end with 5 minutes on goiters. ultrasound makes the diagnosis. More than 20 milliliters for men, more than 18 at women, and more than 16 for teens. Okay, you have to have a good measurement here and a good measurement also in the lab. First step, is it insoluble goiter? You have to say no to 5 questions. Is it painful? Is there an aesthetic or functional discomfort? Is it nodular or at risk for malignancy? Is there a thyroid dysfunction? Is there an autoimmunity? If you say no to all this, it's a simple goiter. So you will need clinical exam, TSH, TPO antibodies, and of course, ultrasound. That will help you to help for treatment. No surgery for autoimmune thyroiditis. Look at this patient, okay? She had a large goiter, but you see, it had all the criteria for autoimmune thyroiditis, and then I treated her with levothyroxine. Autoimmune thyroiditis has hypoechoic goiter with sometimes heterogeneous aspect like Swiss cheese microcystic aspects, leopard aspect, dappled aspect. When you have this aspect, think of autoimmune thyroiditis, and sometimes focal pseudonodular aspect. You can find white knights, okay, hyperechoic nodules in the middle of an hypoechoic thyroiditis, and sometimes multiple white knights, what is called Bonavita's giraffe pattern. Look at an example. When you see this, you say, oh my God, I have 15 nodules to describe. No, zoom back and say to yourself, okay, it's the giraffe pattern. None of these are true nodules. I don't have to describe them. It's the giraffe pattern. So look at Caroline. Sudden appearance of a cervical mass. One day I woke up and there it was. Normal TSH and blood tests. Very anxious. So this is what I showed you. Okay. So after a non-stop day on the internet, she asked evacuation, percutaneous ethanol injection, canal ablation. I suggested reflection. And as you see, it was hypoechoic. As you see, there was inside white knights. In fact, these are white knights. As you see here, you had microcystic aspects, and it has regular lymph nodes here. So it was a bare Hashimoto thyroiditis confirmed by TPO antibodies more than 3,000, levothyroxine, and after 6 months, a 40% decrease of goiter volume. No surgery also for subacute thyroiditis. Okay, this is an example of a subacute thyroiditis. Painful goiter, heterogeneous, with hypoechoic areas, ill-defined margins, always or very often anterior and lateral, coexisting with normal tissue areas, as you see here, and you see very ill-defined margins that can scare the eyes of some people not used to see the thyroiditis. Okay, but the normal tissue areas are a very important diagnosis criteria. You can have focal forms. You can have forms moving from the right to the left, month after month. It's very typical of subacute thyroiditis. In color Doppler, you see that the inflammatory foci are non-vascularized, very poorly vascularized. No systematic surgery for Graves' disease. We saw this sooner. And sometimes you can diagnose a lymphoma. Look at this patient, and there are 2 zones to look at. Here, this huge goiter, painful and rapidly extensive, with echoic zones inside, and these metastatic lymph nodes, very rounded, with reticulations, typical. These 2 are typical of thyroid lymphoma. My conclusion. Now we saw a lot of lesions, but now we can conclude with therapy. Ultrasound for the surgeon, the surgeon will be happy to see the pyramidal lobe because it does not have X-rays instead of eyes. And if you want a real total thyroidectomy and you do not say to your surgeon that there is a pyramidal lobe or ectopies, it will miss it. So look here, you can follow this pyramidal lobe, and here in a longitudinal view, you can see here, okay, it's going to rise high up in the neck. Look, here, here, until here. Arteriolusoria predicts a non-recurrent inferior laryngeal nerve. So you follow the left carotid. If you see the white sign, it means there are no arteriolusoria. But if here it goes from the right to the left, there is arteriolusoria and there is a non-recurrence of the inferior laryngeal nerve. You can also use perform a US laryngoscopy to diagnose vocal cord palsy. Look, after a thermal ablation, you can see the vocal cords moving. And of course, the other part of therapy is interventional US-guided thyroidology. Of course, there is the diagnosis interventional with FNAB, just like here. You can perform evacuations. You will see this fist that can be evacuated. You will see the needle here. It's a good position. I always check for my position. So you will see here the needle entering the cyst and then evacuating it very softly, quietly, and totally. So you see that the trachea is coming, the thyroid parenchyma is coming, and we will evacuate it totally until both parts are glued one to the other, just like this. Thermal ablation, of course, you all heard about thermal ablation. This is my Jedi Master Hervé Montpessin. This is the first French article, or the first article of a French team evaluating our 200 first nodules. And ultrasound matters before the procedure, because whatever the technique, we have to check for the danger zones, because we are going to deliver a lot of heat here around the very important structures. So we have to check for the danger zones. Okay, here you see we have trachea, the esophagus, parathyroid muscles, and vagus nerve, and inferior laryngeal nerve. So we have to know about this if we want to perform interventional radiology. Okay, so some examples of something you are not used to see, like vagus nerve, or here you have other nerves like the spinal nerve. Okay, another example, you can always check for the sympathetic plexus. You can use ultrasound for local anesthesia, just like here, as you see, with xylocaine and naropain at different planes, so that it's complete and non-intravascular or intranodular. You have the laser, and this is an example of the laser, and here is an example of ultrasound treatment with laser. You see the bubbles. That means that the tissue is destroyed. And you have also radio frequency using the moving shot techniques. So here is an example of what you see on the screen, performing a radio frequency from the posterior part to the anterior part, and from the external part to the internal part. Okay, so this is the end of this journey from lesions to therapy. I wanted to thank you for listening this hour of description. I wanted to thank also my Jedi Master, all these people that taught me ultrasound and ultrasound guided techniques, and I could teach myself. So thank you for listening, everybody, and I'm ready for your questions.
Thank you, Edouard. Hi all, if you have any question, you can use the question box or eventually the chat or raise your hand also. We're waiting for you. I hope you have enjoyed this session. And so let's see if you have any questions. I see some. I see some
I'm going
raised.
to the question.
Yeah.
Or the chat also.
I have some raised, and I don't know, Valentina, I have lost the.
As of now, I just see a comment coming, so excellent session, many thanks. No questions yet.
But we have some raised hands, Valentina. I don't know if you can give them the.
Yes, I can see them. So if there is someone who wants to write a question, you can do it directly in the box.
Doros Polidoro has raised his hand. I don't know. I don't know. I have a question meanwhile for you. Edouard, you are using all the focal therapy techniques, right?
All the focal, I use laser and radio frequency because HIFU is not so effective for me. It's a very costly device. So I do not use high intensity focused ultrasound. And I'm going to begin microwave, I think, but I have to learn this. I'm very cautious about this because I want to learn still, but I use the two main techniques, laser and radio frequency.
Okay, thank you. We have a question. Okay, I can send to you the question, but the question is how to differentiate the lymphoma from acute thyroiditis.
First, the context. Lymphoma, you have it with autoimmune thyroiditis. Sometimes it is not known. So when you have just a goiter, lymphoma is quite painful. And when you press it, it does not increase pain. When you have subacute thyroiditis, you cannot press it or the patient will punch you. Okay? First thing. Second thing, you have totally normal thyroid tissue, ill margins, and you have, as I showed you, very, very hypoechoic tissue with non-vascularized, okay? And of course, you have the lymph nodes, very huge reticulated lymph nodes in lymphoma and very small reactive lymph nodes in subacute thyroiditis.
Okay. I think that.
And if you have a doubt, fine needle aspiration biopsy, but it will be too painful in subacute thyroiditis. It will be perfectly feasible in lymphoma.
Okay, I think I have also authorized your microphone, so if you have some question, you can activate your microphone and ask directly the question. If not, I will send you another question, Dr. Ganassia. It's how long you follow up?
U3 nodule.
Ah, okay, yeah.
Perhaps thyroid 3 nodules, I think. What is my unless I've lost the initial session. Okay. So nodules, okay. One nodule, I will follow up. First, I see it. I see him again, huge at 6-12 months. If it's normal, I would say at 18 months. And after this, if it's stable, I will add a year. So 2 years, okay, now I see you in 3 years. It has been 3 years, now I see you in 4 years, okay? And if it's growing, each year. It's rapidly growing 6 to 12 months. And
Okay.
excuse me, very multinodular goiter, no more than 2 years.
Okay, Edward, we have another question.
Yeah.
I just sent it to you.
So incidence of thyroid cancer in Graves went to FNA. There are controversial studies, some saying that it's the same number of cancers. Some say that the prognosis is worse when there is Graves' disease, which is not surprising because you have track TRAB. TRAB are mimicking TSH stimulation. We know it's a growing factor for thyroid cancer. But for diagnosis, which is your question, I say you apply the TIRADS. So of course, in hypoechoic thyroid, it's difficult to say if it's iso, hypoechoic, etc. Consider all the nodules in a thyroid as hypoechoic, so TIRADS 4 or 5, and perform FNAB. But warn your cytopathologist that there is a Graves' disease because it will help him to distinguish it from some artifact. Always warn your pathologist of the clinical context. Always, always, always.
Okay, I saw someone called Fabio who raised his hand. I don't know if you have some question, Fabio. I think you can activate your microphone or something else. And I see, okay, Doros have asked his question. So it said, thank you. And so Giuseppe has also tender thank you. And so, okay, I think we have other questions. So Fabio is silent. So the last question, maybe. Okay, well, the last question for you. Just send it to you. Thyroid atrophy. Any follow-up?
Good question. Usually we say that whether thyroid atrophy, no systematic follow-up. But of course, the patient says, I feel something, or at the palpation you have something abnormal, then you perform, of course, your ultrasound. But do we need to systematically follow up thyroid atrophy? No. Whereas always follow up the goiter of Hashimoto thyroiditis, because these are indeed thyroids that you will find lymphomas.
Okay. Thank you. I think that if we have no more questions, maybe we can close the session. Again, Edouard, thank you so much for this interesting talk. And let's see for another session probably next year. Okay?
If participants have a favorite topic, then I will adapt and I will treat the topic they ask.
Yes, very good point, Dr. Ganassia. So you can send to us your comments and eventually your idea for the next presentation. So don't hesitate to contact us. Thank you so much, everyone, and enjoy your day. Bye.
Bye.
Bye-bye. Bye.